Hi everyone, today I'm here with Dr. Hamler, a double board certified internal medicine and palliative, hospice and palliative medicine physician. And so we're just going to be talking about this specialty today and answering a few of your questions. So first of all, thank you again, Dr. Hamler, for being part of this interview.
My pleasure.
And I'm sure everyone's going to really appreciate you having you here. So before we kind of dive into the details, could you just kind of explain what internal medicine is and also what hospice and palliative medicine is? Since there's kind of confusion about like each of these different specialties.
Certainly. So internal medicine, it's not to be confused with being an intern. Internal medicine has to do with adult medicine. It's basically taking care of adults for their cardiovascular, metabolic, neurologic problems. It's really probably something where you're more familiar with all the subspecialties that branch out from internal medicine, and that includes infectious disease, hematology, the study of blood disorders, oncology, the study and treatment of cancers, gastroenterology, which deals with liver and intestinal issues, the field of pulmonary medicine that deals with chronic lung conditions and asthma, endocrinology that deals with hormone problems, diabetes, thyroid disorders, osteoporosis, neurology, which includes strokes and seizures, migraine, MS. And so it's pretty much the launch point for a variety of subspecialties, but in general internal medicine, we deal in primary care, but also to some extent to the subspecialties, and not to forget cardiology, heart, blood pressure, vascular system. So what I don't do, it's easier to say, is I don't deliver babies, I don't do pediatrics, I don't do surgery. So internal medicine is the launching point for both being in primary care with an emphasis on diagnosis and treatment of medical conditions. It is a type of primary care. And then my other hat is hospice and palliative care. And hospice and palliative care are dealing with helping symptom management for people who are facing a life-threatening illness. So palliative care can be given any point in the trajectory of a serious illness, and it aims to help support patients as they go through this journey of dealing with a critical illness. It can be given in the hospital or in a outpatient setting at home or in a nursing home. Hospice care is really for those people who have no longer options for curative therapy or who no longer want to go through more treatments and are focused on comfort care near the end of life. Hospice is provided for people who have a estimated prognosis of 6 months or less. And so we provide intensive symptom management for patients in that state.
What was your trajectory to coming to internal medicine and deciding on wanting to do hospice and palliative medicine as well?
Well, it was funny. During medical school, I rotated through all the clinical rotations, and I really didn't care for any of them. The medicine actually initially turned me off because the patients all had complex medical problems. They were on, 10 different medications that all looked like a confusing mess. I didn't really care for pediatrics. I did not like surgery at all, and I was really wondering what I would end up doing. But it turned out that medicine seemed to have a calling for me, and I tended to do well in it, and as time has grown on, I've really enjoyed it. Hospice came a little bit later, maybe about 6 to 7 years ago. I was having some of my internal medicine patients on hospice and thought they could be managed better, that their symptoms could be controlled better, and that led to me going to some team meetings for hospice and feeling that this is something I wanted to add to my practice. So I became a team physician for a local hospice company, took the boards and passed, and then left that company and became a medical director for a different company So I'm able to do both outpatient palliative care medicine as well as hospice for another section of patients.
Okay, and so is hospice and palliative medicine a subspecialty of internal medicine, or is it something completely different?
It is a conglomeration. It is a subspecialty of internal medicine, so there is the board certification under the American Board of Internal Medicine, but you can also get certification under anesthesiology, under interventional radiology, and so you can be board certified in hospice and palliative care medicine through a variety of different organizations.
Mm-hmm. How is internal medicine different from family, besides not treating kids and not treating, and maybe not doing as much like OB? Do you do OB-GYN?
I can do pelvic exams and such, but I'm not doing delivery of babies
Mm-hmm.
or surgeries like hysterectomies
Mm-hmm.
or tubal ligations.
Mm-hmm.
Those things would be more in the realm of the gynecological specialty,
Mm-hmm.
which are surgeons. Family medicine has a very broad view of healthcare, and there is a lot of overlap with that in internal medicine. I would say in internal medicine, we're more familiar with pharmacologic therapy. We have more in-depth training in terms of taking care of very ill patients, and we're more of the Sherlock Holmes of medicine. We're the ones who will do the probing diagnostic studies to really find out what's wrong with a person.
Mm-hmm.
So sometimes family medicine doctors will refer patients to me
Mm-hmm.
that they're having trouble figuring out.
Mm-hmm.
Also with family medicine, there's more likelihood that they'll either help set bones or suture lacerations,
Mm-hmm.
Deal with things like that, which is something that I don't do in internal
Mm-hmm.
medicine.
Mm-hmm.
I was initially trained during medical school, but
Mm-hmm.
really I haven't done that
Mm-hmm.
in a long time.
So is internal medicine more of like the thinking, like the thinkers that try to diagnose?
It's considered a cognitive
Mm-hmm.
specialty, whereas family medicine involves a lot more procedures and a broader range of services
Mm-hmm.
and individuals. So yes, I would say that internal medicine is really a cognitive
Mm-hmm.
practice.
Okay, and for hospice and palliative medicine, are there specialties of subspecialties of that too, or is it just one thing?
It's really one thing, although people in it may either spend their time mostly in hospice or may do
Mm-hmm.
a lot of palliative care
Mm-hmm.
work, and sometimes they'll rotate from one field to the other.
Mm-hmm.
So, for example, at UC Davis, they have a palliative care team, but they rotate, the attendings there rotate between their UCD hospice and the palliative care service.
Mm-hmm. What's a typical day in the life or a week if you do different things on different days like for you?
So, years ago, before we had hospitalists taking care of people in the hospital, I would
Mm-hmm.
take care of my patients both in the office, and then if they needed hospitalization, I would take care of them in the hospital as well,
Mm-hmm.
and then just go between here, the office, and the hospital to make rounds and to call in orders or write orders. Now, with the change with more usage of hospitalists, I'm doing mostly outpatient medicine
Mm-hmm.
and seeing people here in the office, usually between 9 and 12 and 1:30 and 5.
Mm-hmm.
And so we'll see, for me, I see about 20 patients a day. Some people see more, some people see less. Some people are in a concierge model of practice.
Mm-hmm.
I'm just a solo internist, which is unusual.
Mm-hmm.
I'm not in a big group,
Yeah.
but I like to have my own patients and follow their medications
Mm-hmm.
and their labs and
Mm-hmm.
referrals. I help refer people to other subspecialists or surgeons or people
Mm-hmm.
outside of internal medicine, depending on their need,
Mm-hmm.
what we find. So I do that most of the week. That's primarily what I do. In between seeing patients, I may handle calls from hospice on different patients for orders.
Mm-hmm.
And then once a week we have team meeting. So I'll meet 1 week with the palliative care team one afternoon, and then the next week I'll meet one afternoon with the hospice team, and that's an interdisciplinary team, nurse, chaplain, home health aide, social worker, team manager, and we discuss each patient on our team and what's happening with them and how we can best address their end-of-life experience.
And so I was going to ask this later on, but since you brought it up, it seems like you can do private still, and then you can also do like hospitals and big groups, which seem to be like more popular nowadays. How often is it that you find a solo practitioner and also like a small group? And then since we don't really learn those skills, like how to manage like groups and things like that or private practice in medical school, how would you recommend people pursue things like that?
The medical society is probably a good place to get some information on the different locations for practice. I had looked at joining groups initially, but I felt that I preferred just the independence of being able to, control my schedule and to control patient flow. And the general experience of many people in different groups was unfavorable, and so it's like there was no big motivation for me to change. Yes, they offer certain conveniences, but figuring out how to run private medical practice or getting a good manager is the key, and then it requires less work than one would initially think. For someone who's not been experienced in business or that type of thing. So there are managers out there who are happy to set up practices and to help people establish. You will find fewer independent medical groups out there. But what we do see are a lot of doctors who start in one group and then are unhappy and go to another group and rotate through, and large medical corporations that are buying different practices, and then patients are sent to those facilities. However, the doctors sometimes are let go from that if the managers feel like they're not providing enough profit or whatever. Then they have to go find employment elsewhere, and that's probably very distressing for them. There's some people who pick a concierge type practice, which I don't feel quite comfortable with that idea, but patients pay an annual fee to be a part of a panel, and then the doctor is always available. I'm pretty much always available unless I go on vacation, then I have another doctor cover for me. But we provide that kind of service without charging, $2,000 a year or something.
Yeah.
Plus, in Concierge, they stress a executive physical, which includes a lot of things that aren't really necessary or called for. So I just have feelings that it's more elite, and I prefer just doing regular solo practice.
And how do you kind of arrange for someone to take over while you're gone? Do you have like is there another practice that like you're friends with? Or?
Yeah, there are other people who are in independent practice who will take turns being on call for. So there's an internist up in Roseville who will cover for me if I take a vacation, and then my patients will call here, my staff will be here, and they'll be able to refill meds and things. But if there's an urgent medical problem, he will see the patients for me. Likewise, when he goes on vacation, I'll cover for him.
Okay, so you just have to network and try to figure it out.
And I generally take my own calls during the week and in the evenings, and I really get very few phone calls.
So are you on call continuously then throughout the week, or?
Pretty much.
Yeah.
Now, if I wanted to have a special night off or something, I can, arrange for someone to cross cover for that.
And how you said you only get a couple calls per day or per week?
After hours. During the day, there probably are about 100 calls per hour that come to the front desk. But we have systems where if it's refills, if it's a question about a medicine, they have a form that they'll fill out to send to me, and I'll answer it usually within 15 minutes. What to do with the patient or what to tell them, like that.
100 an hour, wow, that's...
It's very, if you are here during the regular hours and just see how the phones go, it's very busy.
Seems very intense. What is a misconception about hospice and palliative medicine and also internal medicine?
I would say for patients, they may not know the difference between an intern and internist. Older people do. Older individuals know, internist, and they know that those are people who handle more complex medical issues. So I don't think there's much confusion there. With hospice and palliative care medicine, there is a lot more misunderstanding amongst patients as well as doctors. So for palliative care, many doctors think that's for patients who are dying, who are near the end, and they don't realize that it's a consultative service, that we help them manage their patients and help them get through treatment more effectively and make sure that the patients are comfortable, that their symptoms are managed, that their emotional, spiritual needs are met. With hospice, doctors may think that we just give morphine or that we speed death. In fact, patients on hospice often live as long, if not longer, than patients getting conventional care. The hospice patients are less likely to go to the emergency room or be in the ICU near the end of life. They're more likely to be satisfied with their care, and the families have less stress and less depression with hospice care. So we're doing a lot of educational efforts to try and help the community of physicians out there understand what palliative care and hospice is. But people think, well, my patient's not ready for this, and yet they underestimate the mortality of the diseases they're treating.
And I think also, I remember on our class page someone posted something about how I think one news source mentioned how like John McCain like gave up on treatment or something, versus like he did pursue treatment, but it wasn't like curative treatment, right?
Correct. So people think, hospice, that's giving up. And no, it's just that the goals change from being curative, when there's no longer anything that's going to cure you, to making sure that you are as comfortable and can participate with your friends, family, for as long as possible and in comfort. So most of our patients are actually alive. And we try and make sure that they get intensive treatment, but for symptom control. And often physicians outside of hospice don't do a very good job of end-of-life symptom management. And so we do provide that service. And for me in internal medicine, it's been a nice complement to what I do for my patients. I'm much more aligned with getting advanced directives done, so that I'm clear about what patients would want if they're not able to communicate, to be sure that they have support for their symptoms, and that they know their options, that they don't have to have that next surgery or that next chemotherapy round, that there is an option of just kind of focusing on the bucket list, so to speak.
Okay, and since you mentioned advanced directives, could you quickly explain what are advanced directives and what's the difference between like POLST forms and...
So advanced directives pretty much are for those people, and really all of us should have one. I have one. It names a person who can be responsible for making medical decisions on your behalf if you're unable to participate for whatever reason. It also lays out a rough guide as to what to do if you're diagnosed with a terminal illness, and whether you want to donate organs or not. So it's a good basic form to have that allows someone to make consents for you to accept or decline treatments that might be recommended by the medical team in a situation where you've lost capacity. If you've got capacity, there's no need to look at the advanced directives. A POLST form is for people who are more seriously ill, the ones who are appropriate for palliative care, and it is designed as an actual order that paramedics or emergency medical teams are supposed to follow, because it's actually a physician order for life-sustaining treatment. And patients have choices that they can pick from, and it usually is important to have a nurse practitioner or physician go over it with patients and their families. And it describes different situations. So the first situation is if you have no pulse and you're not breathing, would you want to allow natural death or have CPR? And so it really is saying, like, okay, if you pass, you're dead, do you want to have attempts to revive you? And some patients will want that, and then automatically they get the aggressive treatment, ICU, all this, by default. If they want to allow natural death, then the next section has to do with if you are breathing and have a pulse but you're seriously ill, would you want to just be at home and have comfort measures, transferred to the hospital only if your symptoms can't be controlled? Or would you be willing to be hospitalized and just generally avoid ICU care? So it helps give us a sense of what the patient would want in these different situations. And the final portion is on tube feeding. If you're unable to swallow, and you choke every time you eat, would you want to have a limited trial of a tube feeding? Would you want tube feeding indefinitely, or no tube feeding whatsoever? I don't want to be kept alive with tubes. And so I work with patients to complete POLST forms as well as advanced directives. And they keep the pink form, the POLST form, at home on the refrigerator. We keep a copy in the chart. But in truth, many people will have their cardiac arrest or collapse outside the home, and the POLST is sitting there at home. So in truth, the POLST form may or may not be available depending on where the event occurs, but at least we have a copy should the emergency room contact us. And the Coalition for Compassionate Care of California is working to try and get a electronic-based directory so that EMT personnel can access POLST forms online and know what the patient's preferences are. That hasn't happened quite yet. But that's the basic difference between advanced directives and POLST forms. They both have their place, and they're not always perfectly available when you really need them.
Yeah, unfortunately, but maybe with future advances, we'll be able to kind of get patients what they want.
Yes, and also that's part of the reason that it's important to discuss these issues with patients, because although people in POLST say they want to discuss this with their doctors, many people shy away from it when you actually bring it up. One of the things that palliative care and hospice providers do is work with patients on their advanced directives. So on hospice, you can be full code, you can have a defibrillator in place, and we'll still accept the patient, but we'll work with them to educate them about what these things mean and what they might result in when death does come.
What are the most challenging and rewarding aspects of hospice and palliative medicine, and also internal medicine? Are they different or same? I'm sure probably dealing with death is probably a little more difficult with hospice and palliative medicine, but
actually not.
No?
No, people get very real as death occurs, and the things that they get flustered about, worried about, tend to fall off, and you get to really be with people and understand what's really important in life. So, helping the families with their stress with that can be challenging, but the patients are, it's a special time when they need us the most. And that's when most doctors say there's nothing more I can do for you. So when you talk to most people doing hospice and palliative care medicine, it's incredibly rewarding. With, I would say the challenge there is really the lack of understanding in the community and in the physician community as well of what hospice and palliative care does and what it means. With internal medicine, I'd say the frustrations are that things you might have heard before is that there is often difficulty getting good communication between the hospitalist and the primary care doctor in practice. And that's essential for making sure patients get cared for appropriately, that the hospitalists understand the diagnoses and previous tests that patients have had before their hospitalization, and that the handoff is done accurately following hospitalization. And it may sound like a sorry note, but the reimbursement for cognitive services is still far below what procedure-related specialties get. So, for example, a surgeon will get much more money for doing a procedure than we would get for spending an hour with the patient, really listening to them and examining them and all this. Rheumatology, which is another field of internal medicine that I didn't mention, arthritis and rheumatism, they get paid very little, and yet they take care of some of the sickest patients with lupus, rheumatoid arthritis, ankylosing spondylitis. And it's gratifying work, but many people shy out of these fields because it does involve a lot of work and very little reimbursement. Not that we're all interested in reimbursement, but many people have big student loans that they need to pay off, and so that can be an issue. Plus, they're increasing government regulations that are well-intentioned, but they have side effects of adding to a lot of extra work that doesn't translate into direct patient care. So the push for electronic medical records was done before they really had good platforms for interoperability, sharing information, before the programs really had good ways of capturing clinical impression and data that communicate well with different doctors. The regulations about how to code a visit have become extremely complex, so that leads one to be at risk for being accused of Medi-Cal or Medicare fraud. For example, UCD got nailed because the attendings didn't sign the notes the right way on the medical students, but those rules came in later, and so they were applied retroactively. They had to settle for several $1 million. So I'm probably atypical in that I would favor a national health program, but I also fear how our government would run it. So I think that people should have health care available, but the way I see the way the government manages different health programs is just very frustrating, because it gives a lot of extra administrative work that's not reimbursed to people in the community, and it adds to a little bit of the burnout that we're seeing in physicians.
Okay, so you mentioned two things: how well internal medicine physicians, and I guess hospice and palliative medicine physicians, are compensated. You said maybe not as much as the work they're doing, but how is it relatively compared to like other specialties, for example?
So general internal medicine doesn't make a whole lot of money. I'm definitely comfortable, that's fine. But if you go into the subspecialties, some have much higher incomes than others. So rheumatology and allergy, not real high-paying things. But if you do gastroenterology, where you're doing endoscopies, colonoscopies, again a procedure, or cardiology, where you're doing a heart catheterization or a pacemaker placement, these things generate more money. And dermatology also, because there's a lot of procedures, they're kind of a cross between an internist and a surgeon, because they do a lot of office minor surgeries. So they tend to be more profitable subspecialties. But again, that's a whole different level than the surgical specialties. Ophthalmology, again, much more income. But again, that there's a difference, but it wasn't enough to make me want to go into one of those higher paying specialties, because I just love a little bit of everything now. And so I would miss doing some of the arthritis work or some of the cardiology work if I went into, let's say, dermatology. So I liked staying in general internal medicine, and I would recommend for you and your students, your fellow students, to pick the thing that really calls to their heart, because it makes it worth doing even during the hard times or when there's other frustrations. If you love what you do, that's great.
Yeah.
So a couple of things there. First, I should have mentioned for hospice and palliative care, there's fair reimbursement for hospice, but it's on a capitated basis. For palliative care, right now, there's no formal reimbursement for palliative care services. You can bill for addressing different symptoms that a patient may have, but it's still in a fledgling state as far as being adequately reimbursed and recognized. For students, what I would say is look at the long-term aspects of your lives and not necessarily rush to something that will help you pay off your debt quickly. Look at something that's going to help you look forward to going to work each day, that it's something that you take pride in, that you feel a calling for, that it enriches your life rather than looking for the quick fix.
Okay, and so that probably ties into burnout and work-life balance. Could you kind of expand a little bit more on how you recommend us prevent burnout and also establish work-life balance?
To definitely schedule your vacations, time with your significant others, outside of medicine hobbies. Don't skip meals or sleep, and to get feedback from others, so that if you start getting more irritable or have issues with mood or whatever, that someone that you trust can say, I think you've been working too hard. You wanted me to let you know if I sense that things have changed. So that way we can kind of take care of each other and help each other avoid burnout. So what I've done is I enjoy meditation. I have done scuba diving. I have a dog, and my wife and I make a scheduled time to have date night, so that we have at least one night a week where we can really just go out and do something fun. But I had to schedule that, otherwise each night would be paperwork.
Yeah, is she in medicine too, or?
Nope.
Okay. You're pretty emphatic about that. Is it something you'd not recommend?
Not necessarily. I think that there are certain stresses to a medical marriage, and there actually have been papers written on that. But most of the people in medicine I know are married to nurses or other doctors, and so it's because that's who you're with, and also because you're dealing with high intensity emotions, and that also tends to breed emotional attraction. So see that care commonly. I think that if someone does have a partner who is not in medicine, that they have a fair degree of independence of spirit, so that they're not frustrated when the person who is in medicine is tied up with medical care that often does not respect hours.
How would you recommend us match into a good internal medicine program, or match into a good hospice and palliative medicine program?
Probably the best way is to go and visit. I encourage people to sit in on a hospice meeting if they can, to talk to some of the people who work in these fields, to talk to interns or residents who are in the training program and see what their experience is. I'm not sure if there's a Yelp or not, or whether the I know the AMA has a students association, whether they have their own ratings or feedback, but talking to people who are actually there visiting and seeing what the spirit is like is probably the best way. Because things can look good in print, but the experience is important because you have to consider that your residency is a period where you're going to be feeling, in most cases, very inadequate, very stressed, overwhelmed, questioning whether you really picked the right job at all, whether this field is cut out for you. And so you want to be in a place that's supportive, where the atmosphere is conducive to, progressing.
So really try to scope out the residency spots and see how they're really like before you commit.
Yeah, definitely. Go out and visit. It's worth making the effort to visit. In my senior year of medical school, I actually did electives in Seattle, in Oregon. It's worth spending a month or so at a different place and seeing how different facilities work and how the people are treated.
So you recommend doing away rotations at the different places that you might consider for residency?
Definitely.
How has medicine changed since you started practicing, and where do you see it going in the future?
It's become a lot more regulated. There's been much more focus on evidence-based medicine, much more focus on looking at outcomes, much more technology involved in medicine, and as a result, there's been a bit of a drop in the human side of medicine, which I'm hoping members of your class can provide. There's a certain degree of dehumanization that occurs through medical school and residency, and it's important to maintain that connection because that's really what patients need. They need to know someone cares and that you're going to be their advocate. There's much more corporate structure of medicine, much more of physicians going to larger groups, and it tends to separate and put a bigger barrier between the patient and the physician, and so patients can get a little bit lost in the shuffle. So I think as far as satisfaction, that I'm not sure patients are as happy as they used to be. They have greater expectations because of all the advertisements for the latest this or that, and so they're often disappointed when reality does not fit what they're promised on the ads. And so I think those are some of the bigger changes, certainly regulatory changes, rules on reimbursement. Those are big issues.
Would you choose the same career path again, or is there anything you would change?
I really enjoy internal medicine, so I think I would do it again. I might have done hospice earlier, but I really don't care for delivering babies and surgery. Did not care for that. So I think I'm in the right place. I almost became a teacher of meditation, but decided at the last minute, no, that wasn't for me. So I'm pretty happy with my choices.
So last question, what advice would you give us to become a good doctor?
To consider that each patient you're taking care of has their own story. Consider them like a member of your family, sort of like the golden rule, like, if you were in their shoes, what would you want as far as care? And that if you're feeling annoyed with a person, to investigate yourself and see what it is about their reaction that's triggering something in you. So the more you understand yourself, the easier it'll be to understand other people and how you react to them. But I think it's a marvelous career still, and that it offers a unique opportunity to be with patients in a level where they may not share with other people, and to really have a feeling at the end of the day that you've made a contribution, that you've done something positive.
Great. Well, thank you again, Dr. Homler, for being with us. Guys, let me know down below in the description box if you have any questions for Dr. Homler, and I could maybe ask him and relay that back to you guys. Also, let me know what other specialties you'd like me to interview next. Thanks for watching, and have a great rest of your day.